So we now have Dr. Liam Gilligan, who is a clinical psychologist at the Cambridgeshire and Peterborough NHS Foundation Trust. He's been working with CAMS, which stands for Child and Adolescent Mental Health Services. His interests include attachment theory, attachment disorders, and mental health and neuropsychological implications of early adversity. In particular, Dr. Gilligan looks at how these aspects can be used to understand emerging personality disorder, which hopefully we'll get to know a bit more about. And Dr. Gilligan is also involved in the application of leadership skills in clinical psychology and how these can be used in health and political systems. So so hopefully everything's set up. Hello, can you hear us?
I can hear you. Can you hear me?
Yeah, and we can see the slide. So
lovely. And can I just check by moving that? Can everyone else see that move? Fantastic.
Perfect. Yeah.
So thank you for that lovely introduction. So I'm going to be talking about something which is more of a newer area to my career at the minute, but a little bit about who I am. So my name's Liam Gilligan. I'm a clinical psychologist who currently works at the Croft Child and Family Unit in Cambridge. For those who are unaware, that's a Tier 4 unit working for children and families and children who are under the age of 12. So a really quite specialist kind of mental health hospital for very young children and their families, primarily working with kids with complex attachment difficulties, complex neurodevelopmental profiles, and a lot of challenging behaviour. But as you will hear in a little bit, a lot of our current patients and upcoming patients are young people presenting with eating disorders and feeding difficulties. And we'll talk a little bit about why that might be changing and a little bit about that. Prior to this, I worked in an adolescent team in the community, which has given me lots of exposure to quite significant mental health difficulties in young people. And the focus of today's session is going to be about eating disorders primarily and feeding disorders as well. And I've had quite a bit of experience of working with young people with these difficulties. So, quick one before we begin. I don't know who is out there listening to me. I don't know what your history is, whether you have any difficulties yourself. Obviously this lecture is being recorded, so what I would be asking you to do today is just keep an eye on yourself, look after yourself. You can always come back to this lecture later on if anything in it is particularly difficult to manage or touches too close to home. So take care of yourselves, please. Right, so what am I going to aim to talk about today? Because eating disorders is a huge area to cover in about 40 minutes. So what I'm going to be focusing on is particularly anorexia nervosa and bulimia nervosa, because those are the eating disorders that we are most likely to come across. They're the most prevalent disorders, and they're also the most prevalent disorders when looking at young people and young children. There is also a case to be had for binge eating disorder falling into that, but this is already going to be a bit of a whistle stop, so I didn't want to kind of talk 100 miles an hour just to get that in there as well. What I was also asked to talk about was something called ARFID, which is a relatively newer diagnosis, although it's been floating around in different iterations for a while now. It stands for Avoidant Restrictive Food Intake Disorder, and what we've seen over the course of the pandemic is that young people with this disorder seem to have, well, the numbers presenting services have spiked, so I thought it might be helpful to talk a bit about that as well. Most of what I'll be talking about is primarily linked to adolescents and adults, because those have been the populations for which eating disorders have been studied the most. They present at those particular ages, and the research looking at eating disorders presenting in children under the age of kind of 11 or 12, it's a much rarer population. It's much more understudied. A lot of what we know is based on kind of case reports or small scale projects. So if I can talk to those, I will do at the time. But this is a this is going to be a real overview. And the reason I wanted to do this was because I don't know about yourselves as medical students, but in clinical psychology training, eating disorders are typically a specialist placement. You don't get an awful lot of exposure to them unless you're quite lucky in your adult mental health placement or child mental health placement. And as a consequence, they tend to pick up a reputation of being very scary, being very challenging, but also being quite an unsatisfying area to work in. And actually, I don't necessarily agree with that, having been fortunate enough to work in it, and thought it'd be helpful to talk it through. So this is going to be a bit of a whistle-stop tour of etiology, assessment, formulation, and treatment. So, why is this important? Well, I don't think anyone could have missed the news cycle over the last year, which has talked about the significant rise in eating disorders over the course of the pandemic, as I just mentioned. And there has been lots of discussion as to why this is, talking about the idea of isolation, meaning that people have more time to kind of sit with their thoughts, struggle more with their eating. For our younger populations, the loss of the systems around them, so schools, youth clubs, has meant that their support structures have gone, and lots of talking about kind of lockdown stones and putting on weight and lack of exercise, all stuff that if you are someone who is really struggling with weight and exercise and are likely to be triggering difficulties. But the main thing that people are noticing is that this has caused a significant impact on services. And for myself, talking to colleagues and friends who work not just in mental health settings like psychiatric settings, but paediatric settings, paediatric wards have a much higher prevalence of young people who are struggling to eat than they have done in a long time. So this is really having an impact on the services that we work in. So just as a heads up, I put lots on my slides. I don't necessarily talk to them because I know you can go back and read these later. So sorry in advance. So eating disorders at their core are difficulties associated with eating, weight, shape, and people over-evaluating that and having a real intense need to control it. And what makes these so challenging is actually quite how dangerous they are as a difficulty. As a psychiatric disorder, they have a lot more need for medical management because of the significant difficulties that they place on loads of systems in your body. So even kind of down to cardiac and mind blank. Essentially, they have a huge bodily impact, which can be life-threatening, and they also have an incredibly high rate of suicide attempts. So they are particularly a life-threatening difficulty. They place a huge burden on families around them, be quite stressful. For the young people I work with, parents are often incredibly angry and frustrated and saddened and full of shame and guilt that they just cannot get their children to eat. And as a parent, that is obviously something you are really biologically planning to do to try and make your child survive. And if you are struggling to do that, it can really hit you quite hard. We know that early intervention is key. Treating these difficulties earlier is much better than treating it later as it becomes more kind of chronic and severe. And there's huge overlap with lots of other difficulties. But it's a hugely under-researched area. It doesn't have that kind of pull of interest that difficulties like depression and psychosis do. So, touching a little bit on just what each of these are. So anorexia nervosa is a disorder associated with intense fear of weight gain, causing a person to restrict food and energy intake into their body, or undertaking behaviour that interferes with weight gain. So lots of exercise, overuse and abuse of laxatives, and diuretics and anything else like that. What we find in children is that an element of needing of diagnostic flexibility. So lots of previous symptoms in previous diagnostic manuals talked about period stopping, which is obviously less useful an indicator for children who haven't started puberty. The element of not necessarily relying on BMI, but kind of weight for height, and that children, especially under the age of kind of 11 or 12, are more likely to also restrict fluid as well as food in their presentation, which actually makes it even more dangerous, particularly given they already have a smaller kind of weight and stature. It can cause difficulties to drop quite suddenly. One of the things that we've noticed on our unit is a lot of our children are obviously at the point where they're having growth spurts, and so finding that weight for height was tracking okay, and then having a small growth spurt could suddenly pull someone into a more dangerous range, so having to then be really mindful of the kind of developmental aspects of it as well. What I've put there again is also just men with anorexia. Adolescent men particularly, the focus is often around body shape and muscle size, and rather than weight itself. And there are some statistics for its emergence, but typically emerges between 12 and 15. With some research saying there's a second spike, particularly in women in kind of late 30s, early 40s, but actually for presenting in younger children, really quite rare. So bulimia is even rarer in very young children, much more prevalent in teenagers and adolescents and young women in particular. Essentially, episodes of binge eating alongside recurrent purging behaviours, so vomiting, laxatives or use of diuretics, or very kind of compensating for those difficulties. Again, age of onset is a little bit later and associated with real kind of lack of control over eating in these episodes. People talk about just being in a trance and eating as much as they physically can. And what we know is this is less likely to present in children because they're less likely to have access to either be able to partake in some of these. It's stuff like, for example, a young child being less likely to go out and buy the food necessary to engage in purging, which is something that someone of a more adult persuasion would need to do. And then very quickly on to ARFID. So essentially this is a subset of feeding disorders rather than eating disorders, because what ARFID is about is a persistent failure to meet nutritional needs, leading to weight loss, NG tubes, or significant nutritional deficiency, but it's not due to weight gain or body image disturbance. Or a lack of food. There are other reasons for it, which we'll touch on later. This is the one that we're seeing quite a lot of spikes in, and a lot of young people now presenting with NG tubes that my medical colleagues have told me is really quite unusual and hasn't been like that previously. So I'm just going to really touch on some of the risk factors that make us more vulnerable to eating disorders. So family history, parental obesity, in particularly in bulimia. One of the most prominent risk factors for eating disorders is a history of significant dieting, particularly when starting dieting young. There's lots of research looking at systemic factors. So the idea of if dieting is a kind of family script, a family story, the importance of being thin, staying weight, and very early on that being made obvious, it kind of plants those ideas early. And again, young people who have adverse comments from their family about their appearance, their weight, if people make kind of cracks about their weight, then that is a significant risk factor of pushing people that way. We know there's also lots of personality traits associated with eating disorders, so perfectionism is the big one, but generally just kind of low self-esteem, especially if that gets pulled into your body. And life stress, mixed evidence, more likely to be a general risk factor for general psychopathology, which added into the mix with these others may push you down the eating disorder pathway. And don't want to escape this, that actually eating disorders have a huge sociocultural context. They're more prevalent in Western societies. We know that societies that take on more Western ideas and Western beauty standards then see eating disorders start to uptake, and is particularly found in groups where thinness or is encouraged, so kind of ballet dancers, or interestingly in sports where scoring has a subjective element. So the idea where appearance also needs to be taken into account. And there's lots of research looking at the impact of social media, the idea of biased messaging and advertising. So kind of that chocolate is a guilty pleasure. We've all seen chocolate adverts, the Galaxy adverts of women decadently sitting in the bath, kind of peeling away their decadent chocolate and only having one bite. All plays into this idea that these are kind of guilty pleasures and treats and are not just a certain message about food. And we know that for adolescents, peer and media influences are much more detrimental than parental influences. You know that from a detrimental standpoint, that's when teenagers start caring about what they think than their parents. So there is an element of risk of social contagion in these groups. And I suppose what I would be asking you to think about as future medics and psychologists of the future is, don't underestimate the kind of real impact of public health and early intervention type work for trying to kind of get at these. I'm going to lean on a fantastic illustration from a clinical psychologist, and this idea that services are set up to kind of mop the floors and mop up the difficulties that come to our doors, but actually should we be doing more to kind of turn down the taps? So trying to get involved politically, trying to work with systems around young people rather than just necessarily coming to our door. Okay, so really quickly, kind of talk about assessment of eating disorders. So assessment in mental health is about identifying the right pieces of the puzzle to kind of look at, to pick up and try and pull together. And assessing eating disorders, particularly in adolescence, is really key, because eating disorders are a type of difficulty typically known as egosyntonic. And what that means is the characteristics of the disorder are in line with that young person's goals. They want to lose weight, and the eating disorder is helping them to do it. And that's in comparison to something like anorexia or depression, which might be what we call ego dystonic. These feelings are uncomfortable and I don't want to feel them. So what this means is either young people don't see themselves as having a problem, they will underplay it quite a lot, or they'll actively work against you to try and keep it hidden. So we know on our unit, for example, we've got lots of young people who will water load, so try and drink a lot of water prior to being weighed, will do covert exercise, everything they can just to maintain the difficulty without us knowing. And so it's important to integrate information from multiple perspectives, multiple sources of information, height, weight, parental, friends, what is being observed on your wards, and not just necessarily taking at face value what they say, kind of holding it in mind, because eating, I will always externalize an eating disorder. It's not the person themselves, it's their eating difficulty. They are really good at keeping people unwell. The kind of high risk nature of it means there's a lot of anxiety in the family and professional systems, which impact on assessments. Particularly young people who end up on pediatric wards and are very, very low weight. You will find the system is very quick to try and push them into hospitals or psychiatric units, or ringing the alarm bells for help. And actually what that can do is force you to down a quicker, less considered assessment process, which isn't always helpful. Some of the stuff, it's better to kind of try and slow down and make sense of the difficulties, resisting the push from the kind of systems and institution around you to kind of get it done. And also what we know about the kind of cognitive capacity for young people with eating disorders is that they can really impact on how much they really understand. There's a young person I'm working with at the minute who, if I'm talking with them, just stares right through me. And it's because they are so malnourished that they just cannot really take on what I'm saying. So actually being aware of, do they even understand what's being asked of them? Are they so low weight? And actually we'll talk a bit about treatment, but actually a lot of psychological work can't really start and isn't effective until their weight restored, or at least they're kind of on that pathway. So prior to kind of getting someone in front of you, these are the kind of red flags you might have in front, for people around you or young people you're working with who might be at risk. So I'm not going to go through these, but it's all those early stages of making excuses around meals, people with bulimia might be presenting with kind of grazes on their hands from kind of self-induced vomiting. Especially in younger children, there is an element of being more sensible and mature for their age, and that seems to come with eating difficulties and disorders. So yeah, just I suppose kind of keep these in mind for the future. And poorly named, but the SCOFF is a kind of a 5-question screening. I know that kind of this is quite popular with primary care and GPs, just as a sense of when do I need to kind of look at this more seriously. And this has some pretty decent research evidence behind it in terms of specificity and sensitivity to eating disorders, and might indicate when to kind of move next. Okay, so when we are looking at eating disorders, what are we kind of looking at? So we need to get a good sense of our eating disorder. So when did it start? What triggers it? What's keeping it going? What behaviors are you using? What's your pattern of eating? Your degree of body distortion? So again, just thinking about some of the young people I've worked with in the past, triggers for them have been around kind of when they can smell food. That's when the anxiety will start. We've had young people who even the idea of someone going and preparing their food has led to them trying to kick the door down to be able to kind of witness what's being fed, what's being prepared, just through fear that something might be put into it. For children, everything needs to be considered within a developmental context. So thinking about what stage of development are they at, how much do they understand, understanding it in terms of the system as well. So what are parental attitudes to food? What are parental attitudes to exercise? Lots of young people, obviously further down we talk about like comorbidities like ASD, but some of the rigid thinking that can present in some people with autism mean that they get very hooked into these kind of healthy versus unhealthy dynamics of eating. And if you have parents who are very keen on healthy food and have a very healthy healthy eating exercise narrative, that can be kind of hijacked by the eating disorder, strengthened by those kind of autistic traits into a really significant difficulty, and that's something we've seen before. Differential diagnosis is really important, especially for stuff like ARFID as well. And again, you'll be looking at ideally in adolescents, looking at whether or not wanting to remain low weight is a big factor. But actually, even in young children, eating disorders can start as a way of trying to gain a sense of control. And it's not unusual to see these difficulties start around family difficulties such as divorces or grandparents or parents passing away, or significant transitions, so move to kind of middle schools, high schools, anything that can make someone feel destabilized and out of control can be a push factor towards this, because eating disorders are something to kind of focus down on. Okay, and just to kind of roll back to ARFID. So ARFID, there are kind of 3 broad presentations as to why someone might be restricting their intake of food. And the first one is kind of having a sensory sensitivity. So foods being particularly strong, being unable to tolerate the kind of smell or taste. There's a lot of overlap here with young people on the autism spectrum. There are some people who just have a real lack of interest in food or eating, and it's just this kind of, they find eating to be monotonous. They will often just forget to eat if left to their own devices, get no pleasure from it. And one that I've seen quite a lot of, because they often get referred to psychology, is a fear of aversive consequences. So a fear of vomiting, a fear that food will get stuck in their throat and choke. And that being the reason why they restrict their food so much, sticking to safe foods or only foods that are mushy or foods that won't fill them up in case they are sick. And for those who are kind of interested in this area, there's a interview there, a semi-structured interview, which is really helpful in guiding your thinking around that. Okay, So once you've kind of pulled this information out of these systems and got a sense of what's going on, what mental practitioners will tend to do is, well, we need to formulate. Okay, so assessment is about identifying the puzzle pieces. Formulation is about putting them together in a coherent and understandable way. So for clinical psychologists, formulation is done jointly between the patient and the psychologist. So together building a joint collaborative understanding of what's going on. And the idea being that by doing that, we can then figure out the kind of roadmap to move things forward. How can we disrupt this? How can we change things? And formulation isn't just a one-time thing, one model thing. You can formulate in lots of different ways. So I'm someone who uses a lot of a treatment called cognitive behavioural therapy. And my focus might be more around thoughts, feelings, how they interact, how can we challenge different thoughts. Where someone who is formulating from a family therapy perspective might be more interested in mapping out a genogram, seeing where the kind of narratives and life kind of scripts around food are, and how to shift things from that perspective. It's important to think about how that person wants to make sense of their difficulties. I've worked with people who are not particularly keen on more psychiatric or medical model perspectives. So the idea of giving them a diagnosis of anorexia and going very much down these are your symptoms, these are the treatments, would have caused them to disengage. And actually our focus was much more around family perspectives and a more psychological than medical understanding. And that was enough to keep her on board and keep her engaged in treatment that moved her forward. So just to give you a bit of an idea about what this might look like. So this is a cognitive behavioural model of the development of an eating disorder. So at the top there, you kind of think about it, at the top is your early experiences or things that have made you more vulnerable. And as you move down, those difficulties lead to certain beliefs you hold about yourself, certain rules for life, and lead to the kind of cognitions that you see in eating disorders. I'm fat, I'm ugly, I'm not in control, I need to diet, I need to exercise and restrict. And you can see from here how the assessment questions you have can kind of feed into that model. And we can begin to kind of slot in the, kind of fill in the gaps essentially here. And you can do this for maintenance as well. So thinking here about the kind of negative cognitions leading to low self-esteem making you more vulnerable to worrying about your shape and weight. That could then lead to excessive dietary control. And again, all those factors then feed into maintaining that. What a good formulation does is point to your treatment targets. So looking at this maintenance, if this was the person I was kind of had in front of me, I would be looking at, so starvation state first of all. We know that starvation narrows your interest, makes you more cognitively rigid, low mood, poor concentration. So the first thing we're going to be focusing on is breaking that by getting them eating again at some point, try and wrestle that part away. We might be looking at family factors and seeing, are family inadvertently reinforcing this? We've had parents who would be going for runs every single day, and then coming back and bragging about how far they ran, how kind of much of a workout it was, which can obviously be really difficult for a young person who we're then restricting their exercise. So thinking about, can we modify that to stop that impact on the difficulties as well? So lots of different ways to try and break those cycles. So moving on to treatments. Oh, and just to kind of go back to this, this is a model. I don't think I would ever put something like this in front of a patient, especially young children. They would be much more simplified, working on individual kind of symptoms or linking together much simpler mechanisms at heart. If you kind of throw something like this in front of someone, especially if they're malnourished, they're gonna look through it. So this is something for us to keep in mind, to think about the potential maintenance factors. But in the here and now therapeutic work, you'd be working on stuff much differently. In terms of treatment, the best evidence base for children and young people is family-based interventions. There are loads of reasons for this. The main thrust of it being that as a therapist, I have access to you probably 1 or 2 hours a week at most. So my ability to kind of shift things are limited to that window. If we can get your family on board and the people around you on board, they have much more, you know, they've got you for the rest of the week. They can keep pushing these difficulties, kind of helping you to challenge those symptoms. And what a systemic approach allows you to do is contain the anxiety in the wider system. It empowers parents to kind of do the work and to not inadvertently reinforce difficulties. So again, because eating disorders are so dangerous, they will cause massive amounts of anxiety in families who are scared for their children's safety. And one of the difficulties of a family coming into an inpatient unit, for example, and us taking over care of that child in some way, is parents have often had to work very hard to keep their child as safe as humanly possible, and often had to be very, very controlling in order to do so. It's then incredibly difficult for those parents to then relinquish some of that control when they come into a specialist unit. And so there can be a lot of anxiety about what that means, a lot of fear of judgment that they've not done it well enough, shame and guilt about not being able to feed your child. I mean, I'm a parent myself, and I've got a little one who's a picky eater. You know, will often have really difficult dinners with us, and it really kind of hits at the core of you as a parent of not being able to provide for your kids. And so actually having professionals come in and swoop in to save the day can be really quite difficult. So getting parents on board is incredibly important. And it very much creates an us versus the eating disorder narrative, this kind of idea of externalizing those difficulties. And the metaphor I always use is a tug of war. And what we want is patient, psychologist, MDT, the medical team and the family all on one side of the rope, with the eating disorder on the other side. We all want to be pulling against it. We don't want to leave the patient on the side of the eating disorder, everyone pulling against it. So that's about getting away from judgment, frustration, everything like that. And it has really good outcomes. It's just something I think is often in short supply in the community. It's often something that there's long waiting lists for it. And we know it's much better if we can get them earlier on. For particularly older kids, so those over the age of 11, particularly because of kind of cognitive development and what it involves, there is also CBT for eating disorders. So looking at thoughts, feelings, the kind of subsequent behaviours, trying to disrupt those. Much more individualized. If I'm doing CBT with a young person, I'd still want parent in the room to be my co-therapist. One, so we're modeling the kind of conversations we're having, but two, so that when they go home, I can still remain an annoying psychologist on their shoulder, kind of helping to push back against what the eating disorder is trying to do. What I have become much more mindful of is, obviously, as I said earlier, some young people with eating disorders can come across as much more adult in their presentation, but actually developmentally still may not be able to do some of the kind of cognitive work. So you might be working much more on behavioural interventions, so reinforcing different behaviours. So less about challenging thoughts, more about shifting behaviour. And in kind of full CBT for eating disorders, really focusing on bodily symptoms, getting people acquainted with their body, often kind of weighing people before sessions to challenge. So it can, really quite a difficult therapy for people who are terrified of weight gain. And actually the outcomes for CBT aren't that good. There's a lot of work to be done in improving outcomes. And there's a few other therapies which have some potentially good outcomes to come. So DBT is for use in people with borderline personality disorder typically. It's about emotion regulation. That has shown some really good potential outcomes for people with bulimia, for example, so managing the emotional stress that comes for a binge. The big one in eating disorders is obviously motivation to change. As I said, the goals of the eating disorder and the goals of the young person are often aligned. They want to be skinny, they want to not gain weight, they want to be ideally thin. And what this often means is they are not motivated to change. So in order to keep them alive and keep them alive to a point where we could potentially shift that, we often have to use treatment against someone's will. So especially on the inpatient units, there's a lot of forced feeding through NG tubes, or a real focus on meal support just to get people eating. We know that it's unethical to offer treatment we know won't be successful. Some of the studies have shown that if people aren't making progress within 6 sessions, they probably won't make any progress. So it's good to think about whether or not someone's ready to make change rather than throwing therapies at everyone, because it can either, if you are a person with an eating disorder and are unable to complete treatment, it either ends up with you feeling dejected and that you can't be helped, or what can often happen really unhelpfully is people get labelled treatment resistant, which means that they're no longer offered those in the future, or more significant interventions get kind of placed upon them, or they're often found to kind of not be treatable and potentially moved out of services. So we need to think about the resources available to us and where we can be most useful. ARFID, just really quickly, because it's such an emerging area, there's loads of really interesting stuff coming out of this, and it's all about increasing your exposure to sensory food, kind of really focusing on senses, challenging yourself, pushing it, fear of aversive consequences. I've got young people who I'm doing anxiety hierarchies and going up kind of more challenging foods and kind of showing them, look, you're not going to choke, and each time kind of proving those kind of feared cognitions wrong. Some of the really interesting stuff coming out of the ARFID research, which is kind of highly applicable for eating disorders, is around just the impact of the body on eating, and even stuff as simple as kind of fight or flight. So we know that when a brain is put in a anxiety-provoking situation, you enter a state of fight or flight, getting ready to attack or run away. But we know that in that circumstance, the kind of chemical cascade of your body down regulates any sort of eating, because it's more concerned that you're going to be eaten by a tiger or have to fight something scary and get you ready to run away. What we know about people with eating disorders is that the idea of eating is terrifying, is likely to be kind of launching fight or flight. So we're trying to force these people to eat at a time in which they're absolutely terrified. Their appetite will be suppressed, and even the kind of internal body is not ready to eat. So again, need to be thinking much more about how to use all this information to kind of get these improvements for our patients. And something I'm not going to touch on, but if you are someone who doesn't hold a particularly psychiatric understanding of these difficulties, there are other ways of trying to make sense of them as well, much more about kind of how power sits in society, more social impact. The BPS did something called the Power Threat Meaning Framework a couple of years ago. It's caused a lot of controversy, lots of arguing back and forth. I would, something to have a look at if you would kind of like to think about these things in a different way as well, and kind of see what you think. So I'm hopefully on time, and thank you very much, and would happily take any comments or questions or thoughts.
Thank you very much. My camera isn't working, but I'll just ask some questions if that's okay with you.
Yeah.
So first, this was at the beginning of the talk. Somebody mentioned about how there are quite a lot of positive trends appearing on social media, like ED recovery or veganism with ED recovery, sharing experiences, and whether these trends and conversations make any kind of difference, or if social media is still more harmful than good.
I think it's interesting. I think the increased prevalence of social media it's the double-edged sword. In some areas, what it has done is allowed those pro anorexia, pro eating disorder voices to have a much louder platform. You know, prior to Twitter and Instagram and stuff like that, you know, you would have to kind of search out pro ana websites, whereas actually, you know, they are much more accessible now. You know, our unit deals with under 12s. They all are on TikTok or other kind of social media, which means that stuff is potentially more accessible to them. There's also a very interesting area that's kind of developing, and it's this idea of what they call orthorexia rather than anorexia, which is becoming very fixed on exercise and clean eating. And you know, there's lots of there's not any good research on it in the minute because these things are so hard to kind of get a good grip on. There's potential for those to be kind of gateways into eating disorders, same as stuff like veganism, which, if you obviously no judgment on the kind of ethics of veganism, not at all, but it's just that people can sometimes use very restrictive diets like that as a kind of gateway into those. The flip side of that is the kind of eating disorders recovery and hope movement has never been stronger, and there's lots of people on YouTube who are sharing their story of eating disorder. So it's good and bad, and I suppose it's like that kind of public health shout at the start is how can we push more people who are in those risk categories into the kind of helpful side rather than not falling into the kind of pro-ana stuff.
Thank you very much for that. I also had a question that was sent in private. So what your thoughts are about inpatient services for eating disorder treatments, given that you said that a lot of behaviors are learned from other patients, whether that's
Yep.
good or bad.
So social contagion social contagion is the kind of idea that behaviors are kind of learnt in a group. And so the idea that if you have one person with an eating disorder in a friendship group, social contagions means that those behaviors are more likely to kind of ripple through the other people. We, especially adolescent eating disorders units, we are always really keen, and I'm thinking back to myself as a community practitioner, we are always really hesitant to admit young people to those units unless they absolutely have to, because what you find is that they go in and will learn behaviors that they didn't already have, different techniques. There's also a huge element of competition on these wards, and if anyone's worked on adolescent inpatient units, just general adolescent units, there's often a lot of competition of who's self-harming the most. Again, with eating disorders, there can be competition of who's lost the weight, who can eat the least at meal times. And what you'll often find is in the dining room, often seated, separately with separate meal support from staff, but will still be kind of keeping an eye on who's eaten what, and kind of ranking themselves. And it ties into that wider theme of adolescence being a time where you become much more concerned with your peer group and settling into that. So they have incredibly difficult time. So again, we having to manage quite a lot there, and we, even in our younger ones, we have a lot of competition. Who can eat the least, or who can kind of annoy the staff the most, who can drop the most food, that kind of stuff. So you've got to be careful of that.
Thank you very much. That makes sense. And one last question before we have to move on. What are your thoughts about deep brain stimulation and treatment-resistant AN? As some people think it's quite barbaric, but there are some good early results.
I don't know enough about deep brain stimulation in eating disorders. I've met and worked with someone who had deep brain stimulation for OCD and found it really helpful. I think it's a difficult area, and I think a lot of people are very critical of the idea that you can solve quite complex social biopsychosocial difficulties, but with the kind of biological edge. But there are huge biological attributes to these disorders. So it's a hard one. I don't know enough to comment, but it's a tricky one. If anyone has any other questions, I'm available on Twitter if we need to kind of wind down. Sorry.
That's all right. That's good. Thank you.